The outset, I'd like to thank the organizers for giving me this opportunity. Mine is a difficult task. I'm going to talk about copper in health and disease. So I actually had to prepare for this talk after a long time because it's not quite a normal common garden medical talk that I'm going to give now. More difficult part is to make it interesting. Third more difficult part I'm faced with is I'm sitting against, facing certain hepatologists, pathologists and neurologists who know everything about copper a lot more than me. But I'll try to keep this simple and basic so that this is aimed at basically talking about how copper is useful in health and disease. So for a few basic things, copper is just a chemical element to refresh our chemistry. Atomic number is 29, it's soft, malleable, ductile, and that's a picture of how actually the pure form of copper looks like. We all know it's used in a number of ways. A bit of history is always useful. Can someone identify this picture? It's part of the original Egyptian papyrus, the Edwin Smith surgical papyrus, and it's one of the oldest surgical treatises in trauma. So as early as about 1600 BC, people used to actually apply copper locally to all these wounds and discovered its antiseptic properties and antimicrobial properties. And subsequently it's also been used even in India in 800 BC, and subsequently copper's medicinal values have been thought to a large extent to have helped even people with arthritis, and a lot of people used to wear copper bracelets. And the antimicrobial copper touch surfaces are something that are being nowadays evaluated against the superbugs and our fight against resistant infections. So copper having unique antimicrobial properties against viruses, bacteria and fungi, if you use them actually appropriately, there are a number of studies which are now coming up saying that if you use copper surfaces in hospitals, then there is a sustained reduction of the microbiological burden as well as a sustained rate of hospital-acquired infections in intensive care units. And this is actually an idea as to where all you can actually coat copper in various hospital surfaces because of its antimicrobial properties to prevent hospital-acquired nosocomial infections. Copper is otherwise in health a very essential trace element, and it's an important cofactor for what are known as cuproenzymes. And it's difficult, there are a number of cuproenzymes which are there in the body, but at least we need to know at least that they are involved in very fundamental processes like energy generation, oxygen transport, cellular metabolism and signal transduction. And what everybody else is aware of is usually cytochrome C oxidase. Recent studies have also seen how copper becomes a critical element for major neuronal functions, and the CNS becomes a major target for disorders of copper metabolism. We know only about liver because we are all gastroenterologists and hepatologists, but there is an increasing body of evidence for the association of accumulation of free copper as well as certain neurodegenerative disorders. And what is interesting is that both the accumulation of copper, both copper toxicity as well as a copper deficiency are both associated with brain dysfunction. To give you a broad perspective, the total amount of copper in the adult human body is about 100 grams, and the bones and skeletal muscles make up for most of it purely because of their bulk. But if you look up where are the highest concentrations, they're usually in the liver, brain, kidney and heart, which is why we have sometimes hepatic and neurovulsin in copper excess. In the blood, most of the copper is carried out by, copper is bound to ceruloplasmin, and a smaller percentages basically participate in the exchanges with albumin, transcriprin and alpha-2 macroglobulin. Most of the copper in the human body is present in Cu1 plus form, cuprous form, and then subsequently oxidized to cupric form. 3 plus and 4 plus do not exist much. Most of the copper is mainly absorbed only in the proximal small intestine. The current recommended dietary intake is about little less than 1 milligram per day, and the average daily intake when assessed in population studies is somewhere in the same range of about 1 milligram per day. And these are the common foods from where we get our 1 milligram per day of copper. And everybody who deals with Wilson's disease is familiar as to what are the copper-rich foods. Copper is excreted endogenously in the saliva and gastric fluid in the intestinal liquid, but the main copper excretion is basically via the bile, and the estimated amount of copper in the feces is about, again, the same 1 milligram per day. So the fine balance is maintained between how much we intake and as well as how much we excrete. But more important is the copper homeostasis within the cell. So the intracellular and the extracellular metabolism of copper is actually at a very tight control in order to maintain free copper concentrations at a very, very low level. So this has to be regulated to have a reasonable minimum as well as not to go in excess as well. Because if you have too high free copper, then the redox capacities of the free copper and the ability to actually trigger the production of reactive oxygen species can actually trigger a set of reactions which can be detrimental to the cell. And this is how the bulk of evidence in the role of copper is accumulating in many of the neurodegenerative disorders, not just Wilson's that we deal with, but even Alzheimer's and Parkinson's disease. So to know a little more of copper metabolism, we need to know about a few names. One is the most important human copper transport protein, which is important to transfer the copper into the enterocyte and then into the hepatocyte. And then once inside the hepatocyte, the copper has a chance to basically either bind itself to metallothianines or reduced glutathione or to one of the copper chaperones. So this is an example of what you need to know if you need to know what is Wilson's disease and even if you're dealing with any of the copper thing. So this is a transmembrane protein which is basically very, very important for regulating the copper influx inside the cell. Then once inside the cell, the copper has a chance to either bind through ATOX1, which is a chaperone protein, which links it to ATP7A or 7B, or be taken up by reduced glutathione, or can be, then once it goes up to ATP7A or 7B, most of you are familiar with ATP7B because this is the protein which is generally defective in Wilson's disease. And ATP7B will help the copper to go into the Golgi apparatus and subsequently get excreted through lysosomes into the bile or to get bound to ceruloplasmin and get into the blood. So these are chaperone proteins, COX17, ATOX1, SOD. And who is a chaperone? See, this chaperone protein basically makes sure that the copper doesn't go anywhere once it enters the cell, directly goes, so it just basically leads the copper onto ATP7A and ATP7B. So a chaperone is generally someone who is an older person who basically takes care of smaller people, chaperoning them in any social event. And that is what, so they act like a shuttle, because without chaperones, there would be excess amount of free copper, and the free copper can be either directly scavenged by the metallothianines or the reduced glutathione, or they can cause, the excess free copper can start off their redox reactions and cause damage. Why is it important in neurology? Because free copper crosses the blood-brain barrier. Though we know that the copper transport protein and ATP7A contribute to the net influx of copper towards the CNS, this copper when in excess is potentially toxic. Luckily, because it is sequestrated by the reduced glutathione in the brain, there is a role for a little amount of control against the toxic effects of free copper. Let's talk a little bit about ATP7A and then come to 7B. ATP7A is an intracellular pump which basically transfers copper into the Golgi apparatus in the brain. And this is especially very, very essential not just for the CNS but also for the peripheral nerves. If that doesn't happen, then we do not have the dopamine beta hydroxylase. And if you have ATP7A mutations, then you get an X-linked disease called Menkes disease. A number of us have not seen Menkes disease, but Menkes disease, for your information, is a neurodegenerative disorder that occurs in infants between 6 weeks to 1 year of age, characterized by mental retardation, seizures, lightly pigmented hair, and this is essentially because there is not enough free copper inside the brain cells. Copper keeps on accumulating right in the intestinal level and cannot even be absorbed into the blood. And a similar process occurs at the level of the blood-brain barrier, causing a lack of ions within the CNS. That's a clinical picture of a child with Menkes disease. And the MRI of the CT brains do not show any excess of copper. They just show certain diffuse demyelination changes, cerebral atrophies. And the biochemical picture is basically low serum copper, low ceruloplasmin, along with high DOPA DHPG ratio. And the therapy is actually to give them IV copper. So there's actually, you need to actually give someone IV, intravenous copper, for someone who doesn't have enough copper inside their cells. But this IV copper is not met with a huge amount of success, and recent promising things are also met with gene therapy using adeno-associated viral vectors. The other copper deficiency states are the occipital horn syndrome, ATP7A, and zinc-induced myeloneuropathy. We are all familiar with ATP7B gene, which causes deficits not only for the excretion of copper into the bile, but also in terms of binding of copper to ceruloplasmin. And this is a very important slide that everybody who deals with Wilson's disease needs to know as to how the low ceruloplasmin affects copper. Low ceruloplasmin leads to basically increase in free copper, and once inside there is increased free copper inside the brain, across the blood-brain barrier, it leads to a lot of mitochondrial dysfunction and a lot of oxidative stress to the brain cells, and that is what causes neuronal loss. In addition to this, ceruloplasmin also has it also acts as an enzyme for peroxidase, and therefore a decrease in the peroxidase activity will lead to decreased iron deposits. So zinc competes with intestinal copper intake at the level of the gut and also induces intestinal metallothionein. We'll skip. We'll need to also make a passing mention about Indian childhood cirrhosis. This is a disease which is very unique because this is thought to be due to excess copper overload. The classical characteristics were thought to be micronodular cirrhosis, Mallory-Hyaline, and Ornstein-stainable copper positivity. In 1950s, the reports of ICC started raining in from all over India, and the first major breakthrough was made after seeing that Mallory-Hyaline they thought was unique to this disease. And then a lot of studies were done by collaborations abroad and in Pune, and they thought that this is all related to high levels of copper in the milk. Similar reports of similar disease even occurred in Austria, where they described a similar condition called Tyrolinian childhood cirrhosis. And then there were stray reports from other parts of the world as well, but they thought that this was an idiopathic copper toxicity, maybe related to partly genetically predisposed children who were exposed to a lot of copper. But after a decade-long campaign against using the copper utensils, when copper was replaced by aluminium and stainless steel, with reduction in copper utensils, ICC disappeared too. And only now sporadic reports nowadays. There is also a recent multi-center study by the ICMR which actually negates the entire lot of work which has been done over several years, stating that maybe this is all incidental, the evidence is largely inadequate and circumstantial, and which takes away a lot of the credit which was done by a lot of experienced workers in India. But I think the truth lies somewhere in between. So when you start discovering a disease, then a lot of other centers start discovering a disease. There's no standardization by which you discover a disease. So I'm certain that there was a lot of environmental exposure in Indian childhood cirrhosis did indeed exist. But there will also be other diseases where copper are in excess which can be confused with ICC, which is what probably discredits and leads to this study citing that maybe ICC is not related to environmental exposure. One of the diseases that we are increasingly nowadays seeing is something called PFIC, which is progressive familial intrahepatic cholestasis, which also sometimes occurs in similar conditions. So at least about 10% of those children who were initially labeled as ICC may not have been ICC, but I'm sure 90% or 80% of ICC which was done were all ICC, and it's only because of the withdrawal of copper utensils that ICC is no longer there. Alzheimer's disease is also another condition where copper is important. So the take-home points I wish to say is that copper is an essential trace element and important cofactor with antimicrobial properties. Remember about ATP7B gene mutations and how copper is important in Wilson's? Free copper levels are the ones that are tightly regulated, and that is the one that is toxic about a certain level. So maybe even in management of Wilson's disease, we need to pay special attention to free copper. And thankfully, because of man's interventions, ICC has almost disappeared. Thank you.
ICMR, I don't know. I don't trust this study. You'll tell me why. Because we have experience. Why is that the ICC has disappeared from India after change of these utensils? There may be a genetic defect. We don't know that. But certainly copper excess is producing the liver disease. PFIC is a different story. It doesn't mimic biopsy-wise, histology-wise, accumulation-wise copper deposition in the liver. Then the presentation is pruritus. The outcome of PFIC is entirely different from what is ICC. Once you diagnose ICC, next year without treatment, 1.5 years down the line, the patient will die. That is not the story of PFIC. I don't know how, this is the first time I am hearing that ICMR has negated ICC in India. It's a pan-state phenomenon which has disappeared. So it should be taken with a pinch of salt unless there are other strong studies to suggest that ICC was different.
I think ICC, though we know that still fire under the ashes is there, because last year only our residents are here to tell about the story. We had picked up 2 patients from Bathinda, Punjab. In both the situations, there was history of, boiling, they were top-fed and boiling milk in the brass vessels and so on and so forth. This was there. And classically, they had hepatosplenomegaly, irritability and all that. And histopathology is so characteristic, I must say. In fact, the one of the slides you said something micronodular cirrhosis. This cirrhosis comes once they survive, over the time. We have a survival of Indian childhood cirrhosis who have been treated now 20 years old even. They are carrying micronodular cirrhosis, healthy, wealthy, good in health. They are growing very well. They are studying and so on. No problems at all. Small varices here and there. Otherwise, they are fine. So therefore, ICC still is there, but in some pockets, somewhere, in remote areas. Maybe we are getting some cases from Himachal, hilly state, Haryana, and also Punjab. These are the 2 states. But last year only we picked up 2 cases who came little early, not in a decompensated state. No, there were 3 stages, stage 2 and stage 3. Once you reach to stage 3, you can't make them to survive because they have already decompensated state. But stage 1 and 2 still they can recover with deep and Slovene therapy. Another thing is that we have demonstrated a protein which is abnormal in Indian childhood cirrhosis. I can't tell you in details at this moment, but certainly they have some genetic predisposition because in the family everybody is drinking milk. Other kids are also drinking. Why a particular set of people are getting? There is some abnormality. And disease has died down because of replacement of utensils by steel vessels and so on. Thank you.
I agree with Dr. Srinivas because when I read that ICMR article on that, it's because my interest is, when I started in the late 80s, my interest was mainly on copper and liver disease. That's a 2 paper we published from CMC. We termed it as atypical form of Indian child cirrhosis. To make it shorter, we call it as atypical copper cirrhosis in Indian children. Like, I also can't believe it is totally, maybe because of environmental excess of copper, children were presenting at earlier stage. And because of these utensils were changed, probably what we presented was all the children of little older age group. So definitely there was an environmental exposure to copper. That's why they presented at an early stage. Now these children probably have something like a genetic defect, which makes them also to present at an early stage when there is an environmental excess. When it was delayed, then they are present at a later stage. In fact, I have seen ICC-like picture even in a 17-year-old girl, nurse which sent a biopsy was sent. His picture was very much like ICC, lot of copper. So that's why after that I started calling everything as a copper-associated chronic liver disease rather than naming them as Wilson's disease, atypical form of copper cirrhosis, anything. So that the pathologists give, it is a copper-associated chronic liver disease. Then the clinicians can take it because we published a whole series of cases which they come in a later stage, probably the children do not respond to therapy. I think this is the area which we need to look at it, because Wilson's as such has got a lot of genetic various mutations, and these children probably, these people will have a different type of mutation. The genetic will definitely play a role, and those, we in fact compare the classical Wilson's disease and this atypical copper cirrhosis, and 50% of the children had a family history, siblings death. But that's why I'm saying histology alone will help, but probably we have to club them into things where it is classically Wilson's and the other group is non-Wilson's, whatever name you want to give. But I also cannot believe it is kind of gone. Probably environmental exposure to copper is removed. So we need to watch out in this. People may present at a later stage, and depending on later stage, you may see them as cirrhotic. All our patients which we publish were all cirrhotic. All are above 5 years.
The ICMR study was published a couple of years back, which was done 25 years ago. ICMR took 25 years to publish the study, which was collected in the 80s. If you see the recent table issue of Indian Pediatrics, there is again a big 2-page article on ICC, revisited, where again they refer to that ICMR study. I mean, that study is not actually a study, it's an expert consensus group where people caught, and they said copper has got nothing to, and we don't want to go into the whole background of that, but it's published 2-3 years ago, but it was with ICMR for 22 years, it was lying with them, and then they published it after that. So that itself tells you what you need to.
Yeah, just a last comment. I believe there is a genome sequencing project on childhood cirrhosis. Somebody has studied it, I don't remember the reference, but there have been no mutations identified in that. So that's the reason they are probably. Thanks a lot, I think.
Thank you.